Good morning, everyone. I'd say it's a great-looking crowd out there, but I can't see with all these lights. But thank you for joining us for our symposium. I'm James McBrayer, CEO of Cyclomedica. We've got a great lineup of speakers, wonderful pair that I'd like to introduce when we get a little bit further into the presentation. We're new to the U.S., but we're not new to the world, so we want to make sure that we say hello to you in as many languages as we can put up there. This is the lineup of today's speaker. I'll provide just a quick overview of Technegas and where Technegas is available throughout the world. Our first presenter, Dr. Rafe Bochter, that's going to be an interactive presentation. So as you were coming in, you would have seen a QR code. I'll just ask, once we do get to that interactive portion of the presentation, the QR code will still be up there, but we'll ask not to get ahead because I think it tends to drop out if you don't. So just be mindful of that. Technegas was approved in Canada almost 23 years ago. We're best in class, I suppose, in all those markets in which we're established. The information that we're providing today is for information and scientific purposes only. I'm not trying to do a commercial pitch for that. You need to come to our booth at 1337. Everywhere you see on the screen there in gold, that's where Technegas is available. We're in 66 countries around the world. The U.S. was number 65. We achieved approval by the FDA at the end of 2023. From that point in time, we started building our Technegas systems, and we have a couple on display downstairs that we'd love to take you through. Once approved by the FDA, fortunately, we actually have a very, very broad indications for use, and you'll see that up on the screen there. We're best known for the second bullet point, the evaluation of pulmonary embolism when paired with MAA, but it's that first point, the visualization of pulmonary ventilation, that opens up a whole host of different applications, and you're going to hear a little bit about that in Dr. Svengensen's presentation later. Well, what is Technegas? Technegas is a nano-sized particle. It's created in our Technegas system. Greater than 80% is less than that 1 micron, and because of its nature, its hydrophobic nature, it's very small. Once inhaled, it acts like a true gas. In fact, before it was named as Technegas, it was called pseudo-gas because it has all the properties of an aerosol, but also the benefit of a gas itself. Just briefly, what entails in a Technegas study? On the left-hand side of the screen there, you'll see the Technegas system. It's a synthesis module. It's a piece of capital equipment that's installed at your site. Again, we have two downstairs that you can have a look at and see what the footprint looks like. The actual patient side of things is consumables. The real hero of the story is the Technegas crucible. It's a carbon that actually creates the Technegas particles, encasing the technetium metal in those small platelet size, nano-sized particles. It's administered through a patient administration set that is a closed system with a HEPA filter on it. And that's why in countries that we were established during the COVID pandemic, because of its fast administration, closed system, and when the patient exhales, it's captured within a HEPA filter. Most of those countries continued at the same rate for their ventilation studies. Fortunately, even though that we've been only on the market here in the U.S. For just a little over a year now, we've already starting to see publications, very pleasingly to see in journals. And those are just a highlight of a few that are already available. I think probably one that we'd like to highlight too, this was actually a survey that was taken before we launched into the U.S. It was a 5-country survey, and the 4 out of the 5 countries listed in there, Technegas is extremely well established there. And I think some of the numbers that you see on the right-hand side of the slide kind of tell a story about the wide use and applications of our products. All right, this is what you've come for. I'm very pleased to introduce Dr. Rafe Bakhter. Dr. Bakhter is a senior nuclear medicine physician at the Austin Health in Melbourne. He's also affiliated with the Olivia Newton-John Cancer Research Institute and the School of Cancer Medicine at La Trobe University. Dr. Bakhter is a nuclear cardiology lead at the Austin with a special interest in cardiopulmonary imaging. He's been instrumental in developing the interpretation criteria for VQ scans at the hospital and has contributed significantly to education throughout his work with students and physicians. He's widely published and a frequent speaker at international conferences and a valued member of multiple national and international nuclear medicine societies. Please join me in welcoming Dr. Rafe Bakhter.
Thanks, James, for this nice introduction, and thanks for Cyclomedica for inviting me to present our experience at the Austin Hospital in Australia in the VQ scan. Here are my disclosures. So at the Austin Hospital, we do about more than 900 cases of VQ scan every year. Approximately 850 of them are for acute and chronic pulmonary embolism, and between 50 to 80 cases a year for quantitative analysis. So I will start with a survey, and I would like to ask all of you to cast your vote about if you are doing ventilation images in your practice as a routine or no. Not sure what happened. Yeah, here you go. So please, you can open your device, scan the QR code, and cast your vote. Great, we already have 38 people doing ventilation images and 13 not doing, so keep increasing, very good. Okay. That's nearly triple or 3 times people are doing ventilation versus 15 not doing ventilation. Very good. Okay, next question. Yep, it's gonna come here. Okay, good. How many are using Technegas for ventilation images? So far, the majority for not using Technegas. Yes, majority are not using Technegas. Okay, however, there are approximately 21 using Technegas, which is good. Yep, that's good. Okay, next question. What technique of imaging are you doing typically for VQ scan? SPECT CT is taking the lead, followed by the planner. Very good. So SPECT CT is getting more and more. That's good, that's good. Okay. Now, I'm gonna talk a little bit about the background. So very small, I'm not sure what's happening. Yeah. Very small slide about the background of venous thromboembolism. So it's the third common cardiovascular disease globally, around 17,000 cases every year. 40% are PE, and it's a life-threatening condition, and early diagnosis is crucial to prevent further morbidity and mortality. The diagnosis of a PE, there are many schemes about the rationale of diagnosis of PE. This is the most simplified one that has been published in the ENM in 2009 and has been updated in 2019, and shows that any low clinical likelihood of pulmonary embolism, we do a D-dimer. If it is positive, we do imaging. If it is a negative, we stop at this stage. Any other clinical likelihood of pulmonary embolism other than low, we do imaging, either VQ scan or multi-detector CT, CTPA. And here we come to the golden rule, is that there is no diagnosis of PE without imaging. So at the Austin, we have modified our own appropriate use criteria from the one published in 2019 in the JNM by Waxman, and we do VQ scan for young female in childbearing period, pregnant and breastfeeding ladies, people who are allergic to iodinated contrast, renal impairment, and non-diagnostic CTPA, and at the discretion of the referring physician. And when we go through the cases, we will talk about this in details. So for the diagnosis of PE on a VQ scan, you need a binary reporting, so yes or no, there is a PE or no PE, rather than probabilistic reporting. You need clean and clear images. And what I mean by clean and clear images, so clear images, homogeneous tracer distribution throughout both lungs, and clean images, no clumping of the activity in the airways. And here is the role of the Technegas in providing clear and clean images for ventilation. And we'll move to the main topic of today's presentation, which is the case studies. So the first case is 32-year-old female metastatic colorectal carcinoma presented to the emergency department with tachycardia, chest pain, elevated D-dimer, and the emergency physician just called me during the working hours and said, I need to do a VQ scan urgently. The emergency department is packed with patients. I have excluded every single cause of this symptom, and I am highly suspecting pulmonary embolism. Can you do it urgently, please? He said, yes, bring the patient down, again, we'll do it for you. And here are two sets of images. This is the first set of image, transaxial images. And then here are the second set of images, again, transaxial images. And now I would ask you, which of these two series of images represents the ventilation scan? Is it series A or series B? Can you please cast your voice? Perfect. Okay, so the majority is going for series A, which is the ventilation images. That's very good. Okay, and the reason why I brought this is just to show you that there is no much difference between the quality of the ventilation and perfusion images. And here are the SPECT ventilation and perfusion images. The first row is the ventilation and the second row is the perfusion. Then I'll move to the planar images. And then here is my question. Is there a PE, no PE, or indeterminate for PE? Can you please cast your vote? Yep. Very good. So it's, of course, the majority is negative for PE, and all of you confidently saying there is no PE. And why are you saying no PE? Because the images are very clean and clear. There is no mismatch. There is no even match. So I went back to the emergency physician and said, okay, definitely no PE. The patient doesn't have a PE, and patient has been discharged from the emergency department. And this is the take-home message from this one, is you need a very good ventilation and perfusion images to exclude the PE. Second case, 28-year-old pregnant lady, no known risk factors, acute onset of shortness of breath and tachycardia, elevated D-dimer. This is a very common indication that comes to us at the Austin, and they want to exclude a PE. At that certain day, the Technegas machine was broken, so we did the DTPA aerosol as a ventilation images. And here are the SPECT images, ventilation top row, and then followed by the perfusion images. And you can see there is a heterogeneity of the ventilation throughout both lungs. And here are the planar images. Again, heterogeneous tracer distribution in the ventilation. And here is my question to you. It's not working. Okay. Anyway, is it a positive or a negative scan? So is there a PE or no PE from what you have seen? Okay. PE present, it's taking the lead. Indeterminate, yes. Okay. So quite variable, as you can see. 14 people said PE is present, 20 people PE is absent, and 18 people indeterminate. So I called the obstetrician and I said, okay, this is probably a low probability PE, but I cannot 400% exclude the PE because it's heterogeneous uptake. There's a little bit of a mismatch in the upper pole of the right lobe and in the lower left lobe. So the obstetrician said, no, this is not satisfactory to me. I need to know, yes, there is a PE, there is no PE. This is a pregnant lady, I need to treat or not to treat. So I said, I can't answer this question. What's the solution? What's the next step? I said, okay, bring the patient back if you are happy and the patient is happy, and we'll repeat it with Technegas the following day. And yes, he did this and sent the patient back for a Technegas, and here are the images. So this is the SPECT perfusion and ventilation images, ventilation on the top followed up by the perfusion images. And here are the planar images as well. So all the planar images that I'm presenting today are extracted, reprojected planar images from the SPECT CT. We don't do planar imaging anymore. And now we come to the question. And can you cast your voice, please? Is it a PE, no PE, indeterminate? Yes. So you see how your response has been changed dramatically. So most of you now are saying there is no PE, confidently there is no PE. And this is the take-home message, is that you need that sort of images to say yes or no. And this is the difference between Technegas and another ventilation images like DTPA aerosol. Third case, 48-year-old man, chest pain and shortness of breath, mildly elevated D-dimer, 506, and sent for evaluation of PE. Emergency physician just called and said, this is slightly outside the appropriate use criteria because he is a man, 48 years old. Can we do a VQ scan? And the reason for this is that I want to exclude small subsegmental peripheral emboli because the D-dimer is not highly elevated, it's 5 or 6 borderline. So he said, yes, that's a good indication, we'll do it for you. And this is the planar images, again, extracted planar images from SPECT CT. And can you please cast your vote? Is there a PE or no PE? So the lead is negative for PE, 25 versus 9 so far, and only one indeterminate. Okay, so most of you are saying there is no PE. I totally agree. On the planar images, there is no evidence of PE. But how about this? This is the SPECT CT images, and you can see a clear mismatched wedge-shaped pleural-based defect in the superior segment of the left lower lobe, and no underlying structural changes on the low-dose CT. And there's another one here on the right lung, the right upper lobe, again, a wedge-shaped mismatched segmental perfusion defect. And here is my question. Here is my question. Is there a PE or no PE? Not working? Not working. Anyway, so this is an example of how the planar or the SPECT CT have converted the treatment of the patient from no anticoagulation into anticoagulation. So on the planar images, it's a negative for PE, no indication for anticoagulation, while on the SPECT CT, it is positive for PE in both lungs. So definitely, this is going to be for anticoagulation. This one here is another interesting scenario, 41-year-old man, history of DVT, chest pain and shortness of breath. VQ scan to exclude DVT. This has been referred from the outpatient, from the cardiology outpatient clinic, and the cardiologist is a very nice friend, and he called me and said, okay, Raif, I don't think this is a PE, but this is the only thing that I need to exclude. It's not a classical example of a PE, but I need to exclude it for completeness. So I said, okay, we'll do the VQ scan for you, that's not a problem. And again, here are the planar images. And here is the question. Cast your vote, please. PE or no PE? Okay. Yes. Most of you are saying no PE. Yep, 100% agree. And here is the SPECT CT, wedge-shaped pleural-based perfusion defect in the posterior segment of the left upper lobe. And it's a classical one, okay? And there's another one here, very small subsegmental one in the left lower lobe. If it is only this subsegmental one, I wouldn't care about it because it's not fulfilling the criteria. But given the big one in there, which is in the left upper lobe, this one, okay, I have to call it a PE. And I called the cardiologist and said, this is a PE. So he said, okay, thank you very much. Okay, I'm going to speak to the hematologist and ask them to treat the patient. And he spoke to our colleague hematologist, and he told them this is a patient with a pulmonary embolism we need to treat. So the hematologist called me and said, Raif, I'm not convinced this is a PE. Clinically, it's not a PE. This is an artifact. I said, no, I can't say this is an artifact. Okay, it's fulfilling the criteria of PE. So he said, okay, we get into a conflict here. What to do? He said, okay, I'll do a D-dimer. And if it is positive, I'm going to treat the patient. If it is negative, I'm not going to treat the patient. I suggested to do a CTPA. He said, no, CTPA is going to get me into more confusion because if it's proved negative, then I haven't done anything. This is either a chronic PE or a small PE that's going to be missed on a CTPA. So he said he did the D-dimer, okay, and D-dimer came back as more than 1,000, and he started treating the patient. And 6 months later, he sent the patient back for a VQ scan, and you can see here there is a healing of this perfusion defect or near resolution of the perfusion defect that was present 6 months ago, proving that this was a PE before. And here are the planar images, no much difference because the early planar images were negative as well. Okay, the fifth case, 31-year-old female, COVID positive, shortness of breath and elevated D-dimer, sent to roll out pulmonary embolism. And here are the planar images. And again, I want you to cast your vote. Okay, again, very good. Most of you are saying no PE. Okay, and here are the images. Again, wedge-shaped pleural-based perfusion defect in the superior segment of the left lower lobe. And here is another mismatched defect on the right lower lobe. But can you please look carefully on the low-dose CT? And you can see that it's matching to an area of an opacity on the low-dose CT, so there's an area on consolidation. There is also other areas of consolidation in the right lung. So this one, despite it's a mismatched, it correlates to underlying lung changes or parenchymal lung changes. And here is my question. Is there a PE? Is there a COVID or both? Okay, so half COVID and both. Okay, both is getting more. Yes, I totally agree that's COVID and PE because the first slide was showing a mismatch with no underlying lung changes, and the second one is showing a mismatch, but there is underlying lung changes. So the patient has COVID, but there is a PE with a COVID as well, and it was a very common presentation during the COVID time. And I just want to say, as James said, okay, we did all our patients during the COVID time as ventilation images, and we didn't get any single incidence of transmission of COVID. Limitation of a planar images, all of you are known about it. It doesn't encompass binary reporting, equivocal results, shine through artifact, very hard to estimate defect size, and medial lower lobe is not well seen, and a lot of inter-observer variability. The SPECT is a superior technique, high sensitivity and specificity as compared to the planar images. 41 reduction in the indeterminate rate, and is highly recommended by the ENM guidelines. And this is a study that has been done in 2015 and 2024 about centers using SPECT-CT and planar images, and in 2024, the US centers, approximately 55% were using planar images, while in Canada, 66% VQ SPECT, and France, about 73% using SPECT-CT. The other case is 81-year-old lady, non-DVT, non-COPD, chest pain and elevated D-dimer, and presents for evaluation of PE. And here are SPECT perfusion images. So this is only perfusion images. Okay. What do you think about these images? PE, no PE, indeterminate. Remember, this is a perfusion images only. Okay. So the lead is PE. Many of you are also saying indeterminate. Yes, indeterminate is increasing. Yes, okay. So it's nearly half now, right? 19 versus 18. We'll move on. Okay, so this is the fused images, the perfusion and the CT. Okay, you can see that this perfusion defect is correlating to approximately or nearly normal underlying lung parenchyma. And another one here, again, nearly normal underlying lung parenchyma. And this is the perfusion and ventilation images together. Are you considering your interpretation? Yes, I do, because all what you can see here is a matched perfusion ventilation defects, despite it was correlating to a normal lung parenchyma, but this one here shows that they are matched in the ventilation and perfusion images, and this is definitely because of the patient COPD. And again, here are the planar images for you to be convinced, again, all the defects are matched. So ventilation images is a diagnostic criteria, so we need to do them. They are very essential. They decrease the risk of false positive studies, and it's best for diagnosing PE. Improved specificity when you do ventilation images, and even during the COVID pandemic, considering the risk-benefit of perfusion-only SPECT-CT omitting the ventilation scan could not be justified. This is my second last case, 66-year-old man, severe pulmonary hypertension on the background of rheumatoid disease and pulmonary sarcoidosis, presents for assessment of chronic PE. And here you can see the images. The middle row is the ventilation images, and then the bottom row is the perfusion images. And you can see here a clear matched defects. And this is my second slide. Okay. What do you think? Is it a PE, no PE? Chronic PE, I'm speaking here about chronic PE. Is there a chronic PE, no PE, or indeterminate? So the lead here is for PE is absent. Yes, indeterminate. Okay. So yes, according to the criteria, okay, PE is absent because this is a matched defects. Okay. And when I show you this underlying CT, all these matched defects are corresponding to underlying lung pathology, consolidation, cystic changes. So this is not a PE by definition. So the head of the pulmonary hypertension unit just called me the second day and said, "What are you doing here? This is our matched defects, and they are big defects, and the patient has a pulmonary embolism. These are chronic PE and has led to pulmonary infarcts, and this is why you are seeing a matched defects." And this cardiologist has been trained previously in nuclear medicine in early 80s. Okay, so I said, my colleague, okay, no, this is not fulfilling the criteria for PE, and I'm not saying this is a chronic PE. Okay, he didn't believe me. Okay, and he went and he did this CT. So look at this CT. So So it's all parenchymal lung changes. Patient has rheumatoid disease and sarcoidosis, and all the magnitude effect, as we can see, is corresponding to underlying lung pathology. Definitely, this is not a chronic PE. And when he saw this, he said, now I'm convinced patient doesn't have pulmonary embolism or a chronic pulmonary embolism. This is my last case. 62-year-old female, elevated right diaphragmatic crus and collapse of the right lower lung lobe. VQ scan was ordered for quantitation analysis before diaphragmatic plication. And here are the pre-ventilation and pre-perfusion images prior to the diaphragmatic plication, and you can see there is a large defect in the right middle and lower lung lobe in the perfusion and ventilation images. And here are the images after plication, 6 months after plication. You can see complete regaining of the perfusion and ventilation into the lower 2/3 of the right lung. And in regards to the quantitation, so this is the ventilation quantitation showing that prior to the surgery, the right lung constitutes only 13% as compared to 39% post-plication, and in the perfusion, 3% versus 42% post-plication. So VQ SPECT is a very good modality for quantitation of lung function, the perfusion and the ventilation images, which are two independent physiological processes. And the CT, the adding of the CT, provides anatomical landmarks for accurate numerical calculation of both function. And my conclusions are reliable diagnosis of PE depends on VQ scan. We need to provide binary reporting in all our reports. The quality of images are very important, so ventilation agent should be of a good quality, and here is where Technegas plays an important role. And adding a low-dose CT enhances your experience and adds another diagnostic tool and improves the accuracy. And the dual functioning quantitation is assessed by quantitation VQ scan, and it assesses both the ventilation and perfusion images. And thank you for your attention.
Thank you, Dr. Wachter. We'll have some questions, time permitting, at the end of the session, and when we do, we'll ask you to use the microphone so that those that this is being recorded, and for those that aren't with us today, they can actually hear. I'm very pleased to present our next speaker. It's Dr. Sarah Svengensen, a Tier 2 Canada Research Chair in Translational Pulmonary Imaging and an Assistant Professor of Medicine at McMaster University in Canada. She's also an affiliate scientist at the Firestone Institute for Respiratory Health and Research Institute at St. Joe's in Hamilton, Ontario. Dr. Svengensen's research focuses on using advanced pulmonary imaging techniques to better understand and manage respiratory diseases. She's published over 60 peer-reviewed papers, delivered more than 30 invited lectures worldwide, and has been recognized with several prestigious awards, including the Vanting Postdoctoral Fellowship and the Charles Polanyi Prize. Please join me in welcoming Sarah Svengensen.
Thank you very much, James, for that very kind introduction. And I'm going to switch gears a little bit from our focus of a conventional clinical use case for Technegas SPECT and present recent findings from a research study that was completed by my team at McMaster. And what the results of this study suggest, and that I'll present to you today, is that ventilation defect burden assessed by Technegas SPECT is predictive of lung cancer resection outcomes. I do need to disclose that most of the research I'll be presenting today was funded by Cyclomedica, and this was through an investigator-initiated research grant that was paid to my institution. Okay, so why are we interested in lung cancer resection surgery? Most of us in this room would be well aware that lung cancer is the leading cause of cancer-related deaths. And curative intent lung resection surgery is the optimal treatment option for early-stage lung cancer resection. However, postoperative pulmonary complications are frequent adverse events in this population, affecting approximately 15 to 40% of patients. And these complications, they lead to substantial patient morbidity and mortality, and they have significant clinical and economic impact due to the resulting prolonged hospital stays and ICU admissions. And unfortunately, these complications largely remain inadequately predicted. Now, there are a number of established risk factors for postoperative pulmonary complications, and those are shown here. So the presence of emphysema, older age, inflammation, reduced lung function, and also smoking history. And it's important to emphasize that preoperative evaluation of lung function is a critical aspect of risk assessment and treatment planning for these patients. And what I'm showing here are two guidelines on the selection for patients with lung cancer for surgery. The one on the left is from the British Thoracic Society, and on the right is a statement from the American College of Chest Physicians. And I'm not going to go through these in detail, but the point that I want to make is that both of these guidelines, they recommend preoperative lung function assessment by pulmonary function testing, and that both FEV1 and DLCO be considered in risk assessment and also the decision to resect. But neither guideline recommends lung function assessment by ventilation imaging. And the reality is ventilation is very rarely used in this context clinically. But if we revisit those risk factors that I presented to you on the previous slide, it's been established that in patients without lung cancer, that all of these risk factors are associated with abnormal ventilation assessed by imaging. And this presents an opportunity for better lung function assessment using ventilation imaging. So as a first step towards this opportunity, our objective in this study was to leverage modern, technologically mature, and clinically available ventilation imaging modalities to determine the prevalence and also the clinical significance of the ventilation defect burden in patients undergoing curative intent lung resection surgery. So to address this objective, we designed a single-center prospective 6-week observational study in patients with a resectable lung cancer diagnosis. All of these patients underwent a preoperative study visit that was completed about a week before standard of care resection surgery. And then we followed these patients 4 weeks postoperatively to document the occurrence of postoperative pulmonary complications and also their clinical impact by assessing clinical outcomes in these patients. So at the preoperative study visit, we did a detailed assessment of these patients. We collected demographic data, detailed clinical history and comorbidities. We performed standard of care pulmonary function testing, acquiring or collecting both FEV1 and DLCO, which I had mentioned are guideline-based lung function measurements used in this cohort. And then we performed ventilation imaging, 2 different modalities, but for the purpose of this lecture and this symposium, we'll be focusing on our Technegas SPEC data. Okay, so with this data from this study, I'm going to answer 2 questions for you this afternoon. First, what is the prevalence of abnormal ventilation quantified by Technegas SPEC before lung cancer resection surgery? And then the more important question is, does this abnormal ventilation predict the occurrence and clinical impact of postoperative pulmonary complications? So nearly 240 patients were screened for this study, and ultimately we enrolled 128. And out of 110 participants who completed all of the preoperative assessments, 107 underwent surgical resection and then completed our 4-week follow-up period, and thus were included in our evaluated population. And this table here summarizes the demographics and clinical characteristics of that evaluated population. The mean age was 68 years, 57% of our cohort was female, 56% were ever smokers, meaning that they were current or former smokers, and 30% had a clinical diagnosis of COPD. Now this slide is highlighting 8 representative cases to show you the preoperative ventilation defect burden in these patients. So the top row is showing the age and the sex of these cases, the FEV1 and DLCO. The middle panel is, of course, coronal slice, representative coronal slice of our Technegas SPECT image, and then the bottom panel is a 3D visualization of the whole lung ventilation distribution for each of these patients. And what's quite obvious here is the spatial heterogeneity in ventilation patterns that are visualized by Technegas SPECT, both within and between lung cancer resection candidates. And we can quantify the ventilation defect burden that we see on these images using a quantitative biomarker called the ventilation defect percentage, which is abbreviated VDP. And this is a very intuitive biomarker where the ventilation defect volume is determined by SPECT, and then that's normalized to the total lung volume determined by CT and expressed as a percentage. So here I'm showing SPECT image and corresponding segmented ventilation mask for both a healthy volunteer and a patient with COPD. And the black regions that you're seeing here within the thoracic cavity in the patient with COPD, those are regions that are classified as a ventilation defect. So in the healthy case, the defects are occupying 12% of the lung, and in the COPD case, 62% of the lung isn't being ventilated. So a higher VDP reflects a higher ventilation defect burden. Now, we previously demonstrated that the ventilation defect burden quantified by Technegas SPECT VDP is sensitive to underlying obstructive lung diseases. This plot is showing data that indicates that there's greater ventilation defect burden in patients with COPD compared to those with asthma and no history of obstructive lung disease. And these correlation plots are showing that the ventilation defect burden quantified by Technegas SPECT VDP is correlated with FEV1 over FVC and DLCO, which of course are our standard clinical measures of airflow obstruction and diffusing capacity, respectively. So the take home here is really that a higher ventilation defect burden that can be quantified with Technegas SPECT VDP is associated with worse airflow obstruction and diffusing capacity in the lung. Okay, so coming back to our cases, and I'll be coming back to these quite a few times over the next 10 minutes or so, I've now added the VDP values for each case, which you can see on the bottom in maroon, and as your eye would suggest, as we move from left to right across the slide, we have increasing VDP in these cases. Now, to answer our first question, what is the prevalence of abnormal ventilation quantified by Technegas SPECT before lung cancer resection? Here I'm showing the distribution of the preoperative ventilation defect burden for all participants in this study, and then importantly, the proportion of participants with abnormal ventilation, which was defined by having a VDP greater than the upper limit of normal, which in this study was found to be 18%. So the important message here is that 58% of patients in our cohort had a VDP greater than the upper limit of normal. And what was most interesting is that a subset of those patients with abnormal ventilation had normal FEV1 and DLCO. And this slide is highlighting 2 of those cases that fall into that category. So both the 73-year-old male and the 63-year-old male, they have normal FEV1 and DLCO, so clinically normal lung function based on how these patients are worked up prior to lung cancer resection surgery. But you can see with your eye, and also our quantitative metric reflects that the ventilation is significantly abnormal in both of these cases. Now, we looked at the chest CT, and it did reveal some mild emphysema in both cases. And this is quite important as it suggests that Technegas SPECT is detecting functionally relevant pathology that's not being detected by traditional lung function measurements. But the key question really is, what's the clinical relevance of this? Is abnormal ventilation assessed by Technegas SPECT VDP important to patient outcomes? This slide is summarizing the tumor characteristics and surgical details in the evaluated population. Really, I just want to highlight here that most surgeries were minimally invasive, and the extent of resection was predominantly lobectomy. 41% of our patients had one or more postoperative pulmonary complications during that postoperative follow-up period, and the median length of hospital stay was 3 days. So going back to our cases, I've now added here the resection details, the postoperative complications, excuse me, and the postoperative length of hospital stay. And if we go back to these, I'm now highlighting 2 cases that are clinically very similar. So the 73-year-old female and the 63-year-old male, both normal FEV1 and DLCO. They both had a similar resection, both had video-assisted thoracotomy with to perform a right upper lobe wedge resection. But you'll notice here that the ventilation patterns are strikingly different, with the 63-year-old male having 3 times the VDP as the 73-year-old female. And if you look at the postoperative complications in these patients, the patient with the abnormal VDP had postoperative pulmonary complications in the form of an air leak, and also ended up spending 8 days in hospital. And this was in contrast to the normal ventilation case, which had no postoperative complications and spent 1 day in hospital. And of course, patients with significantly abnormal ventilation, certainly the case on your far right, with 62% of their lung not being ventilated, they're having numerous postoperative complications and spending longer time in hospital. So we then wanted to perform some statistical analysis in our entire cohort. First, looking at the association between the ventilation defect burden and postoperative complications. So we dichotomized our cohort here into those with and without postoperative complications. Excuse me. And if we first look at the evaluated population, we can see that those patients with 1 or more postoperative pulmonary complications had an elevated VDP that was significantly higher compared to those patients without complications. Now, in that subset of patients with normal FEV1 and DLCO, we observed a trend in this direction, although it did not reach statistical significance. But what's really important is to consider this biomarker in the context of known predictors of postoperative complications in these patients. So we've listed here various candidate predictor variables that we integrated into a multivariate logistic regression model to identify independent predictors of postoperative complications. This included age, sex, BMI, comorbidities, smoking history, those standard measures of lung function, FEV1 and DLCO, also surgical details, so the type of surgery and the extent of resection. And essentially what this model showed was that Technegas SPECT VDP is an independent predictor of postoperative complications. So those patients with a higher VDP are at an increased risk of experiencing complications after surgery when adjusting for all of these other known predictor variables. And if we interpret that odds ratio, what that tells us is that for every 1% increase in VDP, the odds of a postoperative complication increased by 16%. So a 12% increase was associated with doubling the odds of having 1 or more complications. We were also interested in looking at the relationship between ventilation defect burden and length of hospital stay. So what I'm showing here are univariate correlation plots associating Technegas SPECT VDP, which is on the y-axis, to length of hospital stay on the x-axis. And what these plots are showing is that preoperative Technegas SPECT VDP is positively correlated with postoperative length of hospital stay in both the evaluated population and in those that subset of patients with normal FEV1 and DLCO. And again, it's important to investigate this relationship in context of the known and clinically used predictor variables. So we performed in this case, multivariate linear regression models to identify independent predictors of length of hospital stay. And this model included the same candidate predictor variables that I had introduced to you in the previous slide. And what this regression model essentially told us was that Technegas SPECT VDP is an independent predictor of postoperative length of hospital stay. And if we interpret the standardized beta value, what this actually suggests is that it may have the strongest relative impact on postoperative length of hospital stay than the other predictor variables included in this model. And if we interpret the unstandardized beta, this tells us that for every 1% increase in VDP, the length of hospital stay is increased by 0.16 days after adjusting for these other known predictor variables. And that 6.2% increase is associated with an additional day in hospital. Okay, I will start to conclude by summarizing the key results from this study. Abnormal ventilation quantified by Technegas SPECT VDP is prevalent before lung cancer resection, even among patients who have normal lung function. So our results reveal that 58% of patients had abnormal ventilation, of whom 33% had normal FEV1 and DLCO. The postoperative follow-up period revealed that ventilation defect burden measured preoperatively was higher in patients who developed postoperative complications compared to those that did not. It was correlated with the length of hospital stay, and most importantly, was an independent and perhaps stronger predictor of postoperative pulmonary complications and length of hospital stay than current best standard clinical lung function measures. I do want to highlight some limitations of our study. This was a single center study without a validation cohort. We did not perform perfusion imaging. And the reported prevalence of abnormal ventilation depends on that upper limit of normal of VDP that we established in this study. And this was essentially determined from a small cohort of healthy volunteers who were imaged at our center. Also, we did not perform quantitative CT due to variable acquisition parameters. So this limited our ability to assess SPECT VDP's predictive value relative to quantitative CT. So to conclude, abnormal ventilation assessed by Technegas SPECT is prevalent prior to lung cancer resection, and it may be a stronger predictor of postoperative complications and length of hospital stay than standard clinical lung function measures. And based on the observations from this study, I'll end by highlighting potential applications of preoperative Technegas SPECT to improve outcomes of patients undergoing curative intent lung resection surgery. There's opportunity to better predict postoperative complications and recovery duration, and this would support surgical risk stratification and optimize resource planning. There's the opportunity to enhance personalized decision-making and preoperative planning to better characterize lung function preoperatively. So we could refine operability assessment criteria for high-risk patients. We could enable more tailored resection strategies, and perhaps better predict post-resection lung function. And finally, there's the opportunity to support risk modification, which is a really big need in this population. And we may be able to do this by identifying ventilation abnormalities as a treatable trait, which can then guide lung function optimization prior to surgery with the hope of improving these outcomes in these patients. So finally, to realize some of those potential applications that I listed on the previous slide, I'll end with a case. This is a 64-year-old male with COPD and CT-confirmed emphysema. You can see the FEV1 is very low. 35% of this patient's lung is functioning. Their DLCO is also low at 42%. And this patient has a central right lower lobe adrenocarcinoma that was determined to require a right lower lobe lobectomy. And essentially all of that area that's highlighted in red is the lung to be removed in this patient. So this is certainly considered a very high-risk case and a difficult decision for the care team to make. But again, these interventions are often curative intent. So I'm now adding the Technegas SPECT image here, and what this reveals is that the lung to be resected was not ventilated. And it's not projecting overly well, but you can see the lung to be removed that's overlaid on the Technegas scan in red. And essentially, this gives much higher confidence to the team to go ahead with this resection surgery, knowing that the functioning lung is going to remain after the resection surgery. This case also represents an opportunity for risk modification. This is a section of the CT scan highlighting mucus plugging that's spatially related to those ventilation defects in the contralateral lung, and this is associated with neutrophilic bronchitis. So the idea here for risk modification is identifying that defect as a treatable trait. If we can reduce the cells and mucus in the airway lumen, we can improve the ventilation preoperatively, and perhaps this will be associated with better outcomes in this patient. Okay, I'll end there by thanking all of my colleagues on this slide who have contributed to this work. Thank you very much.
Well, I want to thank our presenters today, Dr. Bacher for providing us a very insightful overview about how he uses Technegas in his work in diagnosing pulmonary embolism, and we hope that can translate to you all here in the United States. I also want to, leveraging off the unique characteristics of Technegas as a functional ventilation imaging, the insights that Dr. Svengensen provided about the potential beyond PE applications. We hope that kind of challenges you, how you could actually work that into your referring physicians. We're happy to take questions now. We've got a few minutes left. Again, please come up to the microphone so that we can record your question if you have any, but we'd love to hear from you.
Hi, this is Narendra from Philadelphia. This question is for Dr. Swanson. So most of your surgery decisions were taken on the basis of ventilation with the Technegas, and you said this was an independent predictor for the outcomes. I was just wondering, I would say, because if I understood correctly, you said it was all the wedge resection, thoracoscopic, through the video. Do you think that it was an independent predictor for the open surgery? And as I understood, and whatever my knowledge is, that most of the wedge resections, what you do through the video, they are peripheral. So did you find any difference between the deep lesions of your 1 to whatever you are wanting to resect? And the second question is basically, as you mentioned, though it is an independent predictor, but the perfusion is another aspect of resection kind of thing, of any kind of lung lesion. So how do you take into the account as a separate and then combine the two? Yes, I understand that this is independent predictor, but if it is still perfusing and if it's still contributing to your perfusion function of the lung, why would you take it out just on the basis of the ventilation?
Yeah, no, I think those are great questions, and let me try to remember. There was a few hidden in there. So to be clear, I may have missed your first part, but in this study, so we did not alter the resection plan based on the imaging. So the surgical team was blinded to the ventilation imaging in this case. So they were performed without knowledge of ventilation patterns. And you're right that many of these surgeries are now robot-assisted or video-assisted, very small wedge resections. This cohort, and this is representative of what's done at our center, most of these were lobectomies. So, but I think with the ability of imaging to better guide us, we could potentially, the whole idea here is that maybe we can modify the extent of resection, leverage smaller resections or larger resections pending or guided by the functional lung information. I hope that addressed your first question.
No, thank you. I mean, there are no absolute answers to anything.
Yeah.
We are all doing science for that. Thanks.
And then your second question was related to the perfusion. You're absolutely right. A limitation of this study is we did not assess perfusion, but essentially if ventilation isn't getting to that area, we would assume that that area isn't being perfused. That is an assumption, and I think we would want to understand the added value of having both the ventilation and perfusion side of the story in this context as well. But yeah, that was a limitation of this study. We didn't assess that.
Thank you.
Excellent talk. So when you report these ventilation defects, do you do them just qualitatively, like large defect, small defect, or do you do the percentage wise, just like you do the perfusion images?
Yeah, so in this study here, it was an automated quantification pipeline. So we essentially did adaptive thresholding of the signal from the Technegas spec scan, and then we identified ventilated regions and unventilated regions based on an adaptive threshold. So it wasn't manual; it was a quantitative outcome using a in-house built software.
Okay. Like in the perfusion images, like we do the geometric mean of the anterior and the posterior projection, and that's how we get the percentage wise of each section of the lung. Do we do something similar in the ventilation images, or no? I did not understand that right.
I think the question was, is that done clinically, the quantification?
No, like when we have the perfusion images, and we quantify that, okay, right lung is 40% left.
Oh, I see. So
the geometric mean of the anterior and posterior counts.
Yeah, so the regionality, the essentially if it's on a lobar segmental level. So this was a global assessment, but there is the ability to quantify by lobe and then further by bronchopulmonary segment.
So do we do similar thing in the ventilation or we don't? Do we do the geometric mean or we don't?
Sorry, I couldn't hear.
I'm sorry. Like in the perfusion images, we do the geometric mean. Like supposing the right lung or the left lung, it is divided into 3 segments, and then we see, okay, the right upper lobe, the count is 4 in the anterior projection, and then we.
I think the idea here is that we want to get away from that, right, and have a more anatomically correct quantification that's informed based on the patient-specific anatomy of the lobes, rather than kind of, not arbitrary, but just quadrants and things like that. I think that's what you're getting at.
Go ahead, sorry.
Yeah, so we have the power now to quantify or make these measurements in an anatomically correct way that is, reflective of the percentage of the left lower lobe isn't ventilated, or the percentage of the apical segment of the right upper lobe, rather than a more crude assessment.
I think we've hit our overtime now.
Okay.
So maybe you could come up and you continue the discussion. But thank you all for joining us, and come visit us at 1337. Thank you.